So good morning, everyone, and welcome to our neck of the woods. We're very excited, and my clock is already running, and I better start. So let's start. It's from intervention to prevention, a new theme, I think, for us as interventional cardiologists. You will see it all over TCT. I am one of the course directors at TCT. Important for you to note my disclosures specifically to the center that I run here at Mount Sinai. And I'm really excited to talk to you about optimizing and making our interventions durable by prevention. And of course, this whole idea of intervention to prevention is something that we all must be thinking about. So one way, best way, is right there in the cath lab with optimizing how we place our stents, using intravascular imaging and physiology, and the evidence is massive supporting this now. And we're hoping to see guidelines get up there with a class 1 indication in the United States, ACC/AHA. We're waiting for those, but certainly you see very, very clearly when you image, when you optimize your stents, patients do better. We know this. And in fact, the newest data with OCT guidance showing massive improvements in ischemic events after guiding your intervention using optical coherence tomography. But what about this? I didn't like this study at all. I know a lot of you might have liked it. See a vulnerable plaque, put a stent in it. I say, whoa, wait, David Mehran told us something else in ischemia trial. Treat the patient, do medical management, stabilize the plaque. Don't just put a stent in it. But our Korean colleagues think, put a stent in it and look how great we're doing. Please don't buy this data. Let's wait. And I think it's important to note what we have done and where we're going with antiplatelet and antithrombotic regimens with acute coronary syndromes, and especially in our percutaneous coronary intervention. And our quest is looking for this sweet spot in that green spot of this slide, showing we want to get there with the highest ischemic protection and lowest bleeding harm. Can we get there? And I think we're almost there. And now factor 11 inhibitors, I'm going to talk to you about them a little bit. But you see, we need to figure this out at the right time. So that means we've got to put some brains behind this. And it's not one size fits all. We need to understand the patient's bleeding and ischemic risk and really customize our antiplatelet and antithrombotic regimens accordingly. The event-rich timeness is about 3 months after your percutaneous coronary intervention. But bleeding is a gift that keeps on giving, and so is ischemic events, depending on the risk of the patient. And what we have done now is in challenging conventional knowledge of aspirin for everyone for the rest of your lives, especially now with combination of dual antiplatelet therapies. And we challenged this with the Twilight study where we said, withdraw the aspirin. Well, who needs it? It's just keeping patients to bleed. And look at the amount of data that's following, showing that perhaps in patients after PCI, you can peel off aspirin. You can give them a P2Y12 monotherapy, protect them for a longer period of time, and avoid the bleeding issues. And now with the Lancet meta-analysis that we just performed, this seems to be the way to go. And it looks like ticagrelor monotherapy versus DAPT is probably a really great way, especially for acute coronary syndrome patients, because this is what the editorial says. Is this a conclusive evidence for ticagrelor monotherapy? So we're going there, and the guidelines are coming along slowly but surely. They gave us a 2A recommendation. I'm hoping for a 1 very, very soon, but we'll see. But what about the rest of the risk? It's not just about that stent. It's about the patient. And we've got to target the entire residual risk of a patient who has failed primary prevention because they're here with us with an event that requires a percutaneous coronary intervention or a revascularization for that matter. And there is residual cholesterol, inflammatory, thrombotic, triglyceride, LP(a), and more, and diabetes risk. Very, very important. And it's so important to go there because these residual events is what's keeping the global burden of cardiovascular disease at its higher rate. And of course, now we are thinking about, can we go somewhere? Can we uncouple on the thrombotic risk, hemostasis and thrombosis, going above, going to factor 11, to tissue factor, and see if we could absolutely inhibiting there, promote the pathologic thrombosis prevention, but keeping the hemostasis that keeps us not bleeding intact. And that's the whole portion of the factor 11 saga. I call it a saga because it was so exciting, moved on. There are two major programs with small molecules that I'm part of both. But importantly, I think there's antibodies as well going after this. And we saw the AFib program of Oceanic AF with Bayer stop prematurely by the Data Safety Monitoring Board that showed no real effect. And in fact, it looked like there was more strokes. And it made you think, well, maybe factor 11 inhibition isn't the right way to go. But I'd say the dosing matters. And I think this is continuing in the large Librexia program with over 50,000 patients with phase 2 programs that were much more numbers of patients with many, many other dosing. And so far, so good, 50,000 patients ongoing. But beyond antithrombotic therapies, we have to be thinking about LDL lowering strategies. Lower is better. No question about that. Considering more aggressive therapy sooner, faster, and very, very aggressively. And I think that is what we are seeing from all of the data that's out there with alirocumab, showing that the plaques stabilize with intravascular imaging after an acute coronary syndrome. This is pretty unbelievable, these data. And then, of course, longer-term data from FOURIER with evolocumab showing reduction of ischemic events. And now ssRNA programs that are ongoing. And I can tell you, and I'll go very fast. I didn't know I only had 8 minutes in this huge talk, but I'll keep going. There are ongoing programs. I'm showing you these because I'm involved in Victorion 2 and Orion 4. We're going to do a meta-analysis. And really, the idea is, can we get to these patients secondary prevention with Orion 4 and Victorion 2 prevention, and showing that we could reduce with 2 injections a year ischemic events. LP(a) is the other very novel, important perspective, and there's no way I am giving a talk without talking about women. LP(a) in women, LP(a) in women is incredibly important. I tell you, if you are seeing patients in clinic and not measuring their LP(a), you're missing a very, very important piece of the puzzle, because we know it matters. And just publish. Finally, I said, thank you, Paul. You wrote about the healthy men, and now we have data on healthy women. 30-year cardiovascular outcomes in women that just came out in the New England Journal of Medicine, led by Paul Ritker. I'm sorry he's not here. He should be here, showing us that you must think about LP(a), LDL, and C-reactive protein. Inflammation matters in women for sure. Huge correlation with their outcome. And these are young, healthy women. And by the way, note that the incidence of acute coronary syndromes and heart attacks in young women are increasing in our own country, in the United States and Canada, and around the world, by the way. Perhaps we are seeing more and not ignoring women and actually diagnosing them for the first time, but absolutely, we must get to the bottom of this. And as a result, there are lots of trials. Lastly, I'll talk about inflammation. Yesterday, I was on the phone with Wall Street Journal. They're writing something on inflammaging. That's the name of it, and they called me about this because this is an emerging risk factor, incredibly important to understand the inflammatory pathways. We're not rheumatologists, but we will need to understand what else is going on in the body. And by the way, men and women are different biologically. And so it's not just about the sex, it's the biological differences and how we all have different responses to the different stimuli. And it's very, very important even in development of our atherosclerotic plaque. And the concept in acute MI is one that is really, really interesting. IL-6 inhibition acutely, as soon as the MI is diagnosed, and then for the smoldering inflammation down the line for a year after an acute MI versus placebo in this very large study, Artemis. I'm the study co-chair with Adrian Hernandez over at Duke Clinical Research Institute. 10,000 patients will be randomized to ziltivekimab, IL-6 inhibition directly at the time of MI and down the line. So guys, there is a lot more than meets the eye than just putting a stent in it. We've got to prevent and we've got to move forward, and we have to be thinking about all populations. I didn't have enough time to talk about the non-whites, but please let's make sure we do that as well and have a discussion about that underdiagnosis. Thank you so much.